All right, now it's time to talk about the side effects of testosterone replacement therapy. TRT, like any other medical intervention, has side effects. It's important to not get too concerned or alarmed just because there are side effects, but rather you just need to be vigilant. And if you're going to somebody who says that there are no side effects or they're not looking out for them at all, then it's something that could be putting you at risk. So understand that what we're going to talk about here will be both common and uncommon side effects that you may see with testosterone replacement. The good thing about TRT and its associated side effects are they're very easy to monitor and they're actually very easy to intervene in. So it's something that relatively is probably safer than a lot of other therapies because we can do something about the unwanted effects of treatment. So we're going to start first with testosterone itself. And the most common issue that we deal with testosterone replacement therapy is as we drive your testosterone levels up, we often will drive your estrogen levels up or your estradiol levels up. Now this happens because in your body, testosterone is directly converted to E2 or estradiol, an estrogen. Now, even in men, you have the predominant hormone for women, which is estrogen or estradiol. So this needs to happen. You do need some estrogen. If you have zero estradiol, then what you end up having is problems with bone strength, mood swings, and sexual function. So we can't zero this out, but we do want to keep it normal. Elevated estradiol can cause problems with, again, mood swings, hot flashes, fluid retention, and even breast development called the gynecomastia. The male breast tissue is there and should not be stimulated by high levels of estradiol, so we want to keep this normal. Now, this conversion happens because there's an enzyme called aromatase that makes it happen. So to control this, to make sure that this estradiol level stays normal, not too low and not too high, we use a medication called anastrozole. So anastrozole is an aromatase inhibitor. So it inhibits the aromatase so that there is less conversion from testosterone to estradiol. We only use enough of this to make sure that this stays normal. Now that's important because you don't, again, want to drive this into the dirt. At the same time, anastrozole in and of itself is a very cheap, effective, and safe medication. It's usually dosed just once weekly for most guys and can keep this number right where we need it to be in the normal range throughout therapy. Testosterone also causes the increase in your hematocrit, which is a representation of how many red blood cells you have in your bloodstream, essentially. So what happens, this is the second most common thing we would deal with testosterone replacement therapy. So what happens with your red blood cell production, keep in mind it's a job of your bone marrow to take iron and make red blood cells. Red blood cells carry hemoglobin. Hemoglobin carries oxygen. So you need all of that to be able to not just breathe really, but actually to deliver oxygen to your tissues. So having a few more red blood cells than normal is actually sometimes beneficial. That's why you'll see marathon runners or cyclists train at altitude where the air is thinner and there's less oxygen so that their body is forced to make more red blood cells so that when they go run in a competition or cycle in a competition at sea level, they're performing more efficiently because they have more oxygen carrying capacity. So even though that might be a good thing for a cyclist or a marathon runner, it may be a bad thing for you. Keep in mind that if we were to take your blood sample and put it in a test tube, and then put that test tube into the centrifuge, what would happen is all the solid red blood cells would sink to the bottom, all the liquid plasma would float to the top. So out of this 100% of your blood sample, whatever percentage is made up by these solid red blood cells is your hematocrit. So this number is something that I want to see stay under 50%. Now, why does this go up? Testosterone deregulates iron absorption. So you start reclaiming more iron from your diet. And so if your bone marrow sees more raw material for red blood cells, it starts spitting out more red blood cells. Again, as long as that stays normal and you're auto-regulated through that and your hematocrit remains normal, then it's not an issue. But it can cause increases in hematocrit, and certainly that's where you can run into problems. If you increase the number of solid red blood cells in the solution that is blood, then what you end up doing is increasing the viscosity of blood. If blood's thicker, it's harder for the heart to pump. That can cause problems that are mild, like an occasional headache. It may, in moderate levels, cause increases in your blood pressure. And if it's allowed to continue to flourish and cause bigger problems, then you can have issues with spleen enlargement and even blood clots. So you do need to keep a very close eye on this. And the way we typically make sure that this number, your hematocrit, stays a normal percentage is by either blood donation, getting rid of those extra blood cells that we don't need, or dose reduction. Both of those things can serve to normalize your hematocrit. So again, these are the two most common issues we deal with testosterone as side effects, but they're not the only ones. So let's cover a couple more here quickly. So testosterone, just like it's converted into estradiol, it is also converted into DHT, or dihydrotestosterone. So this conversion is also normal. You want to see it happen. DHT, you might have heard about it a lot when they're referring to male pattern balding, and it pulls a trigger for balding, and if you have too much testosterone, that's why you're bald. All that's actually bad data. Really, DHT does pull the trigger of nature's loaded gun when it comes to male pattern balding, so we don't really see a correlation between testosterone and DHT and balding, but DHT is involved in that. What we see is that DHT can influence your sebaceous glands. So you can have increased oiliness of the skin. Now, increased oiliness in your skin can trap more dirt and bacteria, and that can then cause problems with acne. Now, when we're staying in that mid-normal range like we discussed earlier, we don't see a lot of that, but it's certainly a potential. What we worry about a little bit more with DHT is the fact that it influences the prostate. So the prostate is a male-only organ, lives at the neck of the bladder, it's around the tube that you urinate through. So as men get older and have problems with a growing prostate, they often have difficulty urinating. We evaluate those symptoms very carefully in all of our patients and periodically as well. So what we see when somebody has a low testosterone level, they often have a low DHT level, which means they sometimes have a smaller than average prostate. So it's normal to have a normal or sometimes even below normal PSA or low PSA when you have a smaller prostate. Your prostate-specific antigen, or your PSA, is a blood test that was originally made as a serum marker for prostate cancer. So understand that your PSA goes up for a number of reasons. It doesn't just go up with prostate cancer, it goes up with the size of your prostate. So if you have benign prostatic hyperplasia, which is basically non-cancerous growth of your prostate, your PSA will go up. If you have infection or inflammation, like prostatitis, your PSA will go up. Prostatic trauma, if you've been riding on a cycle for too long, on too hard of a saddle, then your PSA actually can go up from that. So understand this is a marker that is very sensitive and really not that specific when it comes to prostate cancer. What we will see often with testosterone replacement therapy is a normalization of the size of your prostate. So when we go from small to average, then sometimes your PSA can go up with that. Keep in mind, your prostate is not getting bigger and bigger and bigger. It's simply going from small to normal. Now, if this happens and your PSA stays stable and normal, that's no issue at all. Prostate cancer is not caused by testosterone in any way, shape, or form. But this is an important point. If there is an undiagnosed cancer in your prostate before you start testosterone replacement, and we then increase your testosterone levels, that cancer will grow more aggressively in the face of more testosterone. So this is the main reason we watch your PSA and your urinary symptoms like a hawk. This almost never happens, especially for our younger patients. This is really very, very rare. This is something we've not seen much in clinical practice, even after treating hundreds of men, but it is a possibility, and therefore we do watch for it carefully. So this is, again, another side effect of therapy. Now, this whole process of testosterone production is controlled by the brain. So some other side effects have to do with how your body reacts to seeing extra testosterone in the body. Now, if the brain is in charge of determining how much testosterone you need, it uses the hypothalamus. Think of it as the thermostat for everything hormonal. It does other things, of course. And then it sends signals to the pituitary gland, which lies just below it, which is often termed the master gland. So you have pituitary here and hypothalamus here. When testosterone is normally produced, what's happening is there's a chemical messenger that comes from the hypothalamus that talks to the pituitary gland. That chemical messenger is called gonadotropin-releasing hormone, or GnRH. In response, the pituitary gland releases two other chemical hormones to the testes. One is called luteinizing hormone, or LH, and the other is called follicular stimulating hormone, or FSH. Luteinizing hormone tells the testes to produce testosterone, follicular stimulating hormone tells the testes to produce sperm, and the primary job of the factories that are the testes is accomplished. So this all works in what we call a negative feedback loop. Testosterone is then converted into estradiol. Estradiol, among other things, is basically sensed by the hypothalamus, and that will determine how much or how little GnRH is produced, and that will determine how much or how little FSH, LH, testosterone, and sperm is produced. So when your testosterone levels dip, your brain increases stimulation and keeps your testosterone levels normal. When your testosterone levels go up, there's suppression that is then released, so you have less GnRH, less LH, less FSH, and less testosterone and sperm is produced. That is if everything is functioning normally. Now, there are three reasons why you can have low testosterone. Either the testes are underproducing, the brain is understimulating, or a mixture of the two. So what we see most often is primary hypogonadism. The testes fail to perform their job of the production of testosterone. So when we decide that we're going to come in and treat this process, the brain recognizes testosterone, that we give you an injection just the way it would naturally produce testosterone. There is no such thing as bioidentical testosterone. It's not exactly like what your body produces. Even in pellets, it's not exactly what your body produces. It's biomimetic. In other words, it's so close to what your body produces that your brain sees it and reacts to it in the same way. So if you have testosterone coming in from outside of the body, the brain's going to notice that it has plenty, so it is now going to reduce the stimulation of the testes. Now, that means you're going to have less LH, less FSH, and less naturally produced testosterone. Even if you're already low, you're going to have further suppression of your natural production. So this also means that you have a suppression of FSH. Again, FSH is telling your testes to produce sperm, so this is where the negative effects on fertility come in. So if you're a man who plans to father children in the future, you need to pay careful attention to this. Using testosterone limits or inhibits your fertility. That's something that can be safeguarded against, and I use air quotes on purpose there because there are some medications that can help mitigate that risk, but there's nothing out there that guarantees that this won't happen. So if you're taking testosterone, whether it be by topical, pellet, or injections, and you plan on having children, know that you're risking your fertility. So with this suppression occurs, what then happens is the factories that are the testes tend to respond by changing either their consistency or size. So you can have a reduction in size of the testes. You can have a suppression of your natural fertility. One way to help jump in this loop is by using another medication called HCG, not growth hormone, human chorionic gonadotropin. This is actually the hormone of pregnancy. It's what's produced by the female uterus that lets us know on the urinary test if somebody's pregnant or not. To your body, however, it looks just like LH. So it will tell your testes to remain active. So it can counteract the effects of the reduction in size of the testes. It can potentially, and that's a big potentially, it can potentially improve your fertility or at least maintain fertility when on testosterone replacement therapy. But there's still a gamble. There's no study out there that proves that HCG will make sure that your fertility stays exactly the way it was at baseline if you're on testosterone replacement therapy. But this is how the body's reacting to testosterone replacement. Keep in mind, it is replacement therapy. I'm not augmenting your natural production. In fact, I'm suppressing what you normally make and keeping your levels normal through treatment.